Good afternoon. We are pleased to continue our series around telehealth programs as we move from models of success to Zoom EHR integration and to today's topic of telehealth reimbursement. I am Joyce Wagner, Director of RCM Services at AZZLY, and your moderator for today. The key points that will be discussed today are telehealth after COVID, common challenges in delivering and coding for telehealth visits, payer awareness and acceptance, most common and painful billing questions. There are most certainly a lot of questions that must be answered as the public health emergency ends and the sustainability of telehealth services will be tested. Even if public support and adoption for the service has been established and providers have a comfort level in using telehealth for high quality mental and SUD programs, we must now affirm the payer support going into the next few years. While the use of telehealth as a mode of service delivery is increasing, providers, clients, and healthcare settings continue to experience challenges related to adoption and implementation. Today, I will be the moderator. The co-moderator is Heather Junkins. She's a member of the RCM team, and most of you that are a member of the AZZLY family know her. Those that are not, we hope you get to know her. Next, we're going to introduce our panelists for today. Our first panelist is Bill Chrisovergis, President and founder of Miami Valley, an outpatient clinic based in Ohio. Next, we have Elias Moran, CEO of Confianza Health, an outpatient clinic based in Arizona. It is a pleasure having both of you with us today and providing insight into your experience with telehealth. We want to give each of you the opportunity to give your perspective on the questions that many providers have asked of us. Let's begin with the first question. Elias, you'll go first. How long did it take you to adopt telehealth, and what were the changing conditions you faced?
Well, we adopted telehealth pretty quickly. It was evident that this was a part of the business that we needed to implement moving forward. And every service that we were going to provide, telehealth was going to be a major component of those services.
Thank you. And next, Bill, do you want to answer the same question? How long did it take you to adopt telehealth, and what were the changing conditions you faced? I believe Bill is having video.
Nope, I'm finally on, so I'm
okay.
Good.
Did you hear the question, or do you
I did not. I'm sorry.
That's all right, hon. How long did it take you to adopt telehealth, and what were the changing conditions you faced?
Oh gosh. Well, it's somewhat of a loaded question because COVID hit. We were not doing telehealth prior to COVID, so we were in a way kind of forced pretty quick. It wasn't, once we got a process in place, we were able to adapt pretty quick in regards to it. And then now it's kind of the standard of care. It's not going away. So we're expanding the telehealth piece of it on our end.
Thank you. Moving on to our next question, let's start with Bill. Payers have instituted strong coding and billing practice. How about the coding for telehealth? Is it straightforward, or does it differ from payer to payer? And what role do modifiers play in ensuring that you are reimbursed?
Yeah, good question. Well, our client base is 97% Medicaid. So ours is pretty straightforward. And there is a modifier for it. And it's relatively simple and easy. We've kind of adopted on our side.
Perfect. And Elias, from your perspective, do you want me to repeat it?
No, I think for telehealth, it was a pretty steep curve, just in general. Learning the billing practices, making sure that our modifiers were correct, making sure that our billing was going out correctly. Which for myself personally, it was a lot to learn and get into, and having AZZLY help that process for us was just amazing. It was absolutely what we needed to be able to come into the field and start providing services.
Thank you for that. So how is the reimbursement rate on telehealth visits? Is it the same as in person? And are there any recent challenges with the payment cycle that users should be aware of? Let's start with you, Bill.
Ours is the same. So it's the same reimbursement if they're there in person or virtually. And then no challenges with the payers as of right now.
And Elias, how about you?
For us, it's different. We do provide out of the office services. We'll go to the homes, to the schools. And telehealth is reimbursed at the same rates as those out of office appointments.
Perfect. Have either of you done anything special to get over the barrier of your clients using technology for their visits? Go ahead, Elias, you go first.
Yeah, absolutely. There's a lot of challenges when it comes to getting people familiar, acclimated, comfortable with using telehealth. So we've had to, a lot of the implications that we've had to make have been in home. So creating systems that we're able to push out to clients. That way it's very easy for them to log in whatever device they're using, and get on to whatever telehealth service that we're providing at the moment. So we've had to do a lot on our side to be able to get past some of those barriers that people have when it comes to telehealth.
And Bill? Same
yeah,
question.
so with our client base, you know, we're the Medicaid population. Interesting enough, most of our folks, if not all of them, have access to either a computer or their own cell phone. At least the state of Ohio, they provide somewhat of smartphones that they provide the Medicaid recipients. So I think there was a little bit of a learning curve, but you know, I was actually surprised on how tech savvy a lot of these folks were, to be honest with you. It did take a little bit of, you know, download this, you know, do that, this is the login and all that type of stuff, but we've kind of streamlined the process from that point now.
Okay. And how has technologies helped you with your revenue cycle management process for the sending of claims and all of the RCM billing functions from before you joined AZZLY? What has changed? Go ahead, Bill. You go ahead and start.
It's changed for the to the positive. I mean, in a substantial way. Not a long story short, I used a third party to kind of help me bill and really put me in a pickle. I had no idea anything about billing. I've never billed a medical claim in my life. And I've told the story a couple times to some people. As I was actually in a McDonald's in Cleveland, Ohio, and I sat there for about 4 hours and started to learn how to bill through Joyce helping me, and spent the whole weekend. So we weren't getting paid anything. The claims were getting denied. The delay in payment was astronomical. It just didn't make sense to me. So yeah, it's been a night and day. There's no doubt about it. So
And Elias, same question. How has technology helped you in the RCM process?
Yeah, it's foundational. It's something that is required to be able to work in this field. Without it, the delays that you would have are just not, they're just not feasible. And with the help that we have found with AZZLY, because we bill also mostly Medicaid, it can get pretty complex. So we've used other providers, and to be able to address those complexities is really tough. And AZZLY's really helped us to be able to get over some of those barriers.
Thank you. Approximately 17% of the claims submitted to payers are denied. It is important that you have a process for follow-up on denials for issues that are not related to lack of coverage or non-covered services. Have you experienced a higher rate of denials with telehealth visits? And for what reason are the denials, if any?
I'll go. I have not. I mean, I haven't seen any higher denial rates for telehealth or anything like that. At the end of the day, it's almost just the status quo. It doesn't matter if it's in person or virtual. It's pretty much the only difference is a modifier, the way it's billed.
Okay, and Elias?
Yeah, I agree. I think the denial rates that we have typically come from something that we've done and not inputting the client correctly. And there's a system in place to where it's easy to be able to make those corrections and then send out the corrected claim and get those reimbursements.
Perfect. And when you're working with your clients to ensure they get paid, what do you find the most commonly overlooked issues in achieving high predictability of billing and payment?
Go ahead, Elias.
Sorry? Elias?
Yeah. Sorry, can you repeat the question?
Yeah, let me give it a little bit. Maybe it's a little bit kind of funky. So let me get it in. When you're submitting claims, what things are important that can almost guarantee that you're going to get that claim paid on the first pass?
Yeah, really the groundwork that it takes, putting a client in, making sure that all the information is correct. If the slightest thing is not inputted correctly, that's when we'll see the denial. And it could be something very simple that we didn't do, like validating an address. And I think that the biggest thing that we make sure we do to make sure we get our claims process through is making sure that everything's correct from the first second that they're inputted into the system. That's probably the most important thing that we've done.
And Bill, same
Yeah,
question.
it's on the front end. It's us client input, and we've I would say literally within the last month and a half, 2 months, we've kind of implemented a monthly auditing process. If somebody's insurance is checking up on their insurance, we got coverage that lapses and stuff like that we try to catch up on. And that's more of on us. So it's all, we've had issues where there was an extra zero, and we were trying to figure out why it's getting denied. I mean, that's on us. So copying it from the MITS system, which is our Medicaid portal, and plugging it in, and doing it that way. So it's all on the front end. We're trying to put safety measures in place. We've got our office manager that kind of handles that now, that was not a task that she was handled with, but now it is, and we'll streamline it the best we can.
Okay. So what effect has the implementation of the charge master been to the billing process for your clients? Both of you bill differently. We're trying to get Bill into an automated world. He's not there yet. And Elias adopted it. So I'm interested in both viewpoints. So Bill, go ahead. What do you have to say about the
You know,
charge?
I'm waiting. I can't wait to get to the point where it's automated. It's more of I think it's more of my staff and dealing with things on our end to kind of get that where I feel comfortable and things are going to be automated. It's I just know how many hours, or not hours, but you know, time that I'll get back not dealing with the billing myself. So it's more of a, I guess it's more of a trust thing on my end to let control up. So I've done it before, and I don't want to get burned in so that's a different story.
And Elias, you've embraced it from the very beginning since I met you. Tell us what you think about it.
Yeah, I've always been jump 2 feet first and figure out what happens. You know, I think it's a necessary structure to have that charge master. It's important to implement the charge master correctly to begin with, because we, like you said, we jumped right in, and so we've had to make changes to the charge master, which were necessary, and it got a little bit confusing for a minute there, but having a good charge master is really kind of like the backbone to be able to send out these claims, to have it automated, because there's just too much to be doing each and every individual claim. There really does have to be an automated system, and that charge master really is kind of like the backbone to that.
Okay. And talk to us about an organization that's going to do its own coding and claims management. What would you tell them that they need in order to be able to do that?
They need AZZLY. That's what I would tell them. Because you need somebody that knows what they're doing. They know the codes. They have other clients where they've implemented this. It's really, if you're going to be starting out, it's really where you need to have that support to begin with, or you're just going to be making a lot of mistakes along the way. And
Bill?
Yeah, so here's my stance on it is, it doesn't matter if you use Epic for the hospital-based, or a smaller EHR system for urology, or AZZLY for the behavioral health side. You know, the one thing, there's always going to be little snags. The things that I look for is how quick can they be addressed, which are very quick with AZZLY, and we're notified. And we notify AZZLY if something on our end, which is addressed. And when we run into a pickle, if I call somebody, I can have somebody on the phone within 20 minutes and have something corrected. So there's always going to be something that comes up. For me, is how quick can we get it addressed? We had a major shift in Ohio with this Medicaid redesign that was a total nightmare. We had to rebill and redo all this stuff. And thanks to Joyce and her team and Heather and the help to get that corrected pretty quick, because we were and there was a lot of people in Ohio that were in the same boat as me. So those are the things I look for. The other thing that I would recommend is not only having one person dedicated on your staff, have 1 or 2 people kind of trained on understanding it. You know, we're in a world now where, you know, you can have the most loyal person here, but there's always going to be turnover. So don't be stuck in don't put yourself in a corner where it kind of puts your hands are tied, and you're kind of taking 3 steps back versus, you know, the other way. So those are some of the things that I look for. But, you know, like I said, timely response, things that are addressed, I get paid quickly. You know, the claims go through clean from the AZZLY side. And, you know, when I need to train somebody, then that's relatively quick to do as well.
Okay. Successful organizations are constantly reevaluating their future. As it pertains to billing and telehealth, what keeps you up at night? Bill?
there's a lot of things that keep me up at night, but telehealth wise, you know, I know it's going to be the standard of care moving forward. I've kind of adopted that. We tried the whole, like, let's start bringing people back in. And, you know, my thing is I want people in our place more than, you know, in person and have groups and things like that. But at the end of the day, that's not the way the industry's going. That's not the way it's, we have to adopt to it. So that's the first thing is, but you know, what major change or what major obstacles are we going to have to overcome that the state and the payers are going to put in place, you know, in 6 months from now? You know, Ohio Medicaid put something out as they're now starting gathering feedback from particular agencies on their thoughts on telehealth and all this type of stuff. So, you know, what's going to throw a wrench in everything? You know what I mean? I mean, we're going to have to really pivot and stuff like that. That keeps me up at night. That's something that keeps me up at night from the telehealth side.
Thank you. And Elias, how about you?
Yeah, no, I agree with everything that Bill's saying. Changes to Medicaid are probably the biggest concern that I have in being able to meet those billing requirements. Though that's probably the biggest concern that I have. The changes that they implement come pretty quick with very little kind of notice. So, and implementing those changes through our EHR is something that I'm glad that I have AZZLY to be able to work really closely with, because I wouldn't know how to make those changes or meet those requirements that they put out. So that's kind of something that always is in the back of my mind, what changes they're gonna have moving forward and how we're gonna meet them.
We want to thank both of you for being with us today and sharing your views and comments on the different subjects. We've had some questions and answers come in, and so I'm going to start with my beloved Heather and ask her some questions, and she's going to give you the billing know-how. So the first question, are there any specific payer-specific timeline filing requirements for telehealth visits?
Yes, and they vary from plan to plan, with some allowing 90 days and others, such as Medicare, that just allow 1 year. But most have detailed documentation to support their guidelines.
Perfect. The next question, do payers prefer certain modifiers on any code sets for services provided?
Yes, and it depends on the codes, and there isn't a one-size-fits-all for any of the payers. It's very important to determine the required modifiers for the payers and the services that they provide, or they'll reject the claims once they're attached.
Perfect. And are there differences between mental health care billing and substance use disorder billing?
There are. So when you bill by level of care, the mental health procedure code or modifiers are frequently different. If it's an institutional claim, the revenue code will be different as opposed to a professional.
Any challenges with patients receiving concurrent SUD and mental health services?
The documenting the diagnoses and creating the claim with dual diagnoses have been challenging, and also applying the appropriate modifiers for each of those.
Tell us about the telehealth rates in comparison to in-person sessions.
Well, like Bill and Elias both said, there shouldn't be any difference in rates. You should see the same for in-person as well as telehealth.
And can you share with our audience the most common and correct modifiers and place of service for telehealth services?
Yes. So professional claims will use a 95 modifier, and the institutional claims will use the GT modifier with a place of service of 2 or 10. And each of these will be included on that fee schedule, and they have instructions on their payer websites. But the 2 is it's telehealth provided in the patient, not in the patient's home. And then the 90 or the 10 would be in the patient's home or anywhere else.
And we see this because we have psychiatrists who are now using telehealth, and that patient may be in a residential facility, and they may come to them and provide services by telehealth. So
That's
knowing
correct.
those two modifiers and the place of service on claims is key to getting those claims paid.
Absolutely.
And when should a modifier be added to a CPT code?
Anytime that more explanation is required, and it's especially beneficial to indicate a level of education for the rendering provider. The more education that provider has, of course, the higher reimbursement rate you'll get. So those modifiers are very, very important.
Okay. And what are the most common mistakes in using modifiers?
Not attaching the modifier when it's required, attaching the wrong one. Those are both very common mistakes.
And most payers have fee schedules, and on those fee schedules, the modifiers are generally there. So we encourage all of you, especially if you're in Medicaid, pull up the Medicaid fee schedule or pull the Anthem fee schedule. And instead of waiting until your revenue stream is affected, be proactive and learn what is required of you.
Yes.
We want to thank Bill, Elias, and Heather for sharing with us today. And thank you all for attending. I don't see any more questions in the Q&A box. We did not get to everyone. Some of them are individualized, and we will be sending responses out to you after the session ends. We also are going to be having a credentialing seminar webinar this summer, and any of those who want to learn more from the experts, we're going to have 3 credentialing experts, hopefully, that will be on, and each has a different perspective on the importance of being credentialed properly, getting your facility set up appropriately, and getting your providers credentialed appropriately.